I'm Dr. Anthony Kaveh, a Stanford and Harvard-trained anesthesiologist and integrative medicine specialist. And I have a profound respect for neuroscientists. I worked with so many as an undergrad and as a medical student at Stanford. And I learned a lot from them, and I also learned a lot after I began medical practice that shows the divide in some ways behind bench neuroscience and real-life clinical practice around neuroscience. And in anesthesia, where we have medications that directly affect the brain, we have a privileged way of looking at neuroscience, unlike anywhere else in the world. And a privilege to work with patients in their most vulnerable states under anesthesia that also is a powerful window that often is missed in people trying to sell supplements, whether for depression, for distractibility, like stimulants, psychedelics. There is so much money to be made off of vulnerable patients that I really want you to know these 4 things that YouTuber type scientists may often miss compared to physicians who are also scientists, often working in the trenches with patients. Because too many of my patients feel like they're a bag of chemicals being treated when they're on this operating room table. And that is the last thing I want anyone to feel, because in reality, you are so much more than a bunch of circulating norepinephrine, dopamine, serotonin, and other neuropeptides that are just floating around your body and your brain. And it comes to show through these 4 things. One is interperson variability, which is brought out under anesthesia. The second is allergies, and what allergies really demonstrate about these differences. Number 3 is the difference in mindset between patients that has a profound impact on the study of neuroscience. And lastly is the humility about receptor distributions and what the actions of these receptors are. We really don't know, not only for medications like what I'm holding here, which is some fentanyl, but the propofol I showed you earlier, and all the gases that come out of the ventilator behind me. And you know, this is live and unscripted, so feel free to ask questions. I'll try to answer as many as I can. And as always, if you appreciate me coming in here after a long day in the operating room, I'd appreciate your support by sharing what you learned with others to help empower others to take control over their health. You often have more power over your health than you've ever been told. Please spread that message. And if you could hit that like button and subscribe to keep up with my lives, I'd always appreciate that. I don't sell supplements. I don't do any advertising here. This is for you to learn and to benefit from. So number 1 is interperson variability. I practice in the San Francisco Bay Area. And you know, there's this stereotype that everyone is a special snowflake. Everyone is so unique and has different needs and identities. Well, that's one side of a spectrum. The other side is that everyone is an amorphous blob. And unfortunately, we kind of fall on one side or the other. Very few physicians, or really quite frankly anyone else, is willing to look at the middle ground where, yes, there is tremendous variability between patients that we need to appreciate. Well, there's also some commonalities. I just came back from a trip from Japan where the dietary advice, for example, that I often give my patients is not followed at all in that country. Yet that country often has incredible health outcomes that my patients don't have. And that's the dose of humility that I need to take as a physician. There is a lot we don't know. And anesthesia is a powerful example because interperson variability means that different people have variable responses to a medication. Something like propofol, and please listen up because this is very special. This medication goes directly into a vein, into your brain, crosses the blood-brain barrier, and within seconds has a particular effect. However, that effect is highly variable depending on different doses. I just had 2 patients recently who at the same dose, at the same body weight, had 2 completely different responses to this medication. That alone shows that even the same chemical can have relatively different effects based on body weight. However, you need to recognize that, look at anything that you're putting in your mouth and how different it is than propofol that goes in your IV. That's because if you eat something, it has to go through your gut biome first. So that's one degree that people never talk about. Turns out, did you know this, that duloxetine, aka Cymbalta, a powerful SNRI, might be sequestered in your gut based on the bacteria in your gut. No one talks about this. You know, we call patients non-compliant because we give them medications, they don't get better. So we think, well, John Smith must have never actually taken the medications. They were non-compliant with their medications. Well, maybe the gut biome, meaning the bacteria in your small and mostly large intestines, were chewing on the duloxetine or sequestering it so it could never hit, your blood-brain barrier to actually help your depression or anxiety. So propofol avoids that, it still has variability. Then you have the question about genetic polymorphisms. Look at codeine, for example, oral medication with a tremendous variability in how it's processed by human bodies based on genetic polymorphisms or genetic differences. Propofol does not seem to have that many, yet there's still tremendous variability. Do you see the theme here? And then there's the question about bioavailability. So when you take, for example, ketamine, so in my ketamine infusion clinic, I give IV ketamine because I want to have the most targeted way of addressing somebody's mental health. When you take oral ketamine, there is about 10 to 30% that actually makes it to your brain after you look at what is processed by the liver, what actually makes it through the lining of your gut, etc. The bioavailability is much different. Propofol is 100% bioavailable, or IV ketamine is 100% bioavailable, meaning that even when you bypass the bioavailability problem, you bypass the microbiome problem, and you bypass the genetic polymorphisms, you still have so much variability between people. And that's a dose of humility for anyone who's trying to sell a supplement that's taken orally and trying to make a claim that it actually has these tremendous life-changing effects on people. I have a lot of fear. If you haven't actually looked a patient in the eye and cared for them and carried responsibility for them, in a place like here in the operating room, or quite frankly anywhere, where someone's under your direct responsibility, not over social media, but one-to-one like that, recognizing the limitations of anything that you're putting in your mouth. And a corollary to this number one point is that in the studies that people cite, please, please, please look at the inclusion and exclusion criteria. This is so often missed in people that just look at the one-liner from a paper and they try to draw a conclusion. They don't recognize that maybe a study looked at, for example, valerian root for anxiety. Hey, I love valerian root. I love I love natural medications whenever, or natural supplements whenever possible. But if you're looking at valerian for anxiety, who did they look at in the study? If you want to talk about real good neuroscience, a good neuroscientist will say, well, they didn't include people maybe with PTSD when they're looking at their anxiety. So you can treat somebody with valerian root whose anxiety stems from PTSD until the cows come home without actually addressing what the underlying cause of their anxiety is. That's the exclusion criteria of a study versus who is included in the study. Very, very important to always recognize. And most people throw it out the door because they don't read the methods section of a paper. So let's move on to number two. The number two reason is allergies. And this is really powerful to recognize because how many people come to me, or maybe you yourself recognize this, with allergies to foods, allergies to medications, allergies to people sometimes. Hopefully you're not allergic to me, but okay, putting that one aside, allergic to topical products. So if you want to appreciate interperson variability, everyone isn't a special snowflake, but everyone isn't the same amorphous blob either. There are differences in people, and allergies really point that out. The same food in you and me can have vastly different effects from an allergic standpoint, with or without celiac being a reason. For example, if we're looking at gluten, how about people who can't tolerate certain fruits? People that can't tolerate dairy, people that can't sample, that you should know about in any way, shape, or form. People truly are different. I'm not saying you're overly individual, but we have to respect that not everyone's the same. Number three, the mindset that people come in trying to heal with. If you're trying to heal, you need to recognize that if it's some sort of pain in particular you're trying to heal from, which most of my patients, whether that's physical pain or emotional pain, pain has a heavy impact, has a heavy influence from our nervous system and our mindset. But I need to give a shout out first. Ty Wilson says, thanks, you've really helped me understand what happens in surgery. I'm going under the knife tomorrow. I want everyone here to send Ty Wilson positive vibes and positive energy for their surgery tomorrow. And Ty, if you're willing to share what surgery you're having, I'm sure others will also benefit from hearing your vulnerability and sharing that, and hopefully in sharing some positive energy with you. I certainly am. Thank you for sharing, Ty. Now, about the mindset. When we have any type of pain, our mindset shapes that pain. And if you want proof for this, look at the placebo effect. Look at how impactful placebos can be and how different the responses to placebos can be. And then look at how powerful nocebos can be. Nocebo meaning a noxious placebo. So for example, if I tell you that, oh, this pill might help you feel better, you take the sugar pill and you feel better, that's a placebo response. But if I tell you this pill is going to make you feel nauseous, and I give you that sugar pill and you feel nauseous, we call that a nocebo effect. So thank you, Wrath of Canada, for your comment there. I appreciate that. So the placebo and nocebo effect underscore how impactful the mindset is. So when we're looking at studies where we're giving people psychotropic medications or supplements, I gave valerian root as just one example. St. John's wort is another powerful example. But what about the mindset that people bring in? Because that might completely overwhelm the chemical effect from the relatively minor modulations of norepinephrine and serotonin in particular from these SSRI-like supplements or from medications themselves. Maybe you're looking at Prozac versus Zoloft. What's the mindset of somebody coming in? If it's not acknowledged, you're doing that patient who you're responsible for a disservice, possibly disempowering them as well. Now, the fourth one, actually, I need to give you a couple other examples I just remembered. How about the white coat syndrome? If somebody comes to my office and I'm wearing my white coat and their blood pressure goes through the roof, and I say, oh, well, we need to treat your blood pressure with metoprolol and other beta blockers maybe, or calcium channel blockers, or Norvasc, whatever. What was the mindset? When they were anxious and they came in, you can't just treat that blood pressure without saying, why was their blood pressure elevated in the first place? Isn't that totally missing the underlying point? What was their mindset? How about insomnia? Another very powerful example, because patients come to me all the time with sleeping difficulties. So what if I had a patient who came in and said, Doc, I am having trouble sleeping. And I just jumped to magnesium, melatonin, passion flower tea before bed, or any other number of true effective supplements, but without asking, what's the patient feel that their problem is, or feel that they're struggling to heal from? Maybe they have trauma from the bedroom they've been, because they've been abused. Maybe they've lost somebody recently and they're ruminating, perseverating over that loss, and that's keeping them up at night. Maybe it's because they've experienced the loss of a loved one in that house, and that's keeping them up at night. You could imagine any number of scenarios. If we don't address what that underlying cause is, I can give all the melatonin I want without addressing the mindset component of the actual symptom the patient is presenting with. And how can we do good medicine? This is the art and science of medicine, guys. It's not just the science of medicine, because you are not the average person who's coming to me with a neurologic condition. I've read straight out of the studies. You have differences. You have an individualized history, a narrative that you're bringing to the office. So number four is humility in recognizing that we don't know how the vast majority of psychotropic medications work. So come here and look at this medication here. This is called sevoflurane. This is when we deliver anesthesia, we turn the knob here, and it comes out of this ventilator, you breathe it into the patient. I showed you propofol earlier. These medications, especially the gases, act on many different receptors in the brain. The other one, by the way, here is nitrous oxide, or laughing gas. You see this N2O? Laughing gas. So it is such a, pardon me, but a joke to think that, oh, nitrous oxide, laughing gas affects the NMDA receptor in the brain, and that's how it causes people to feel loopy. Just as much as it would be to say that, oh, we know how Zoloft works, it's an SSRI, it increases serotonin levels, and that's why people feel better with it. This is just totally not respecting the complexity of the human body. By the way, Crunchy Celery, I love your username, and thank you for that, thanks, I appreciate that. So, receptors, if you remember from the past, I've said that receptors are like hands. If you give something to the receptor that it can accept, the cell that the receptor is on will respond. So if I'm a big cell, you give me something in my hand, my receptor, I'll say thank you, simple type of thing, right? But now imagine at the cellular level, you have a receptor, and this is a vial of fentanyl. The fentanyl comes on here. The cell will respond by doing what? In most cases, its response is to decrease transmission across whatever, the periaqueductal gray in the brainstem, spinal cord. Don't worry about that specific function. The point is that that is an example of one receptor and one action. When we give nitrous oxide, there's probably hundreds of receptors that we don't even know about that it's acting on. So to try to say that, oh, we know it acts, we know exactly how it acts, and this is why it works, because this is the receptor that it works on. Psychedelics are the classic example. We say, oh, they're serotonin inducing. Just because we know that ketamine, for example, affects serotonin levels, is a joke to think that that's how it works. To think that we have, pardon me, but the arrogance that we actually understand how consciousness and the human body functions around consciousness. This is in part because of the Western biomedical model reducing human beings to chemical reactions in little bags. Oh, I am a mantis. Well, I am mantis, thank you for that. Thank you as well. That's very kind of you. So I'm not saying that neuroscience is wrong. No, neuroscience advisors at UCSF when I was an undergrad at Berkeley and at Stanford were amazingly intelligent, thoughtful people who are moving medicine forward. But I just see too many of them pushing narratives that reduce my patients who I care for under my responsibility to nothing more than just bags of chemicals. And when patients tell me that they feel like their doctor's office is like a pill mill, or they feel like they're on a conveyor belt for surgery like this one, just going down a conveyor belt, I can't help but feel concerned that perhaps patients are not being treated like the individual human being that they are, but are rather falling into the human doing way of looking at medicine. I'll end with the example of caffeine, because we all know caffeine, right? Like we know it's in coffee and tea all over the natural world. But look at how differently caffeine affects people. You know people that can drink a pot of coffee at night and fall asleep just fine. And you probably know people who can have 1 cup of coffee at 7 a.m. and can't sleep through the night. Look at the variability of the response. And this is from caffeine. We know the caffeine receptor. We know what the receptor is. Guys, this isn't nitrous oxide. It's not anesthesia gas. It's not a psychedelic. It's like such a straightforward chemical that we've known about for over 80 years. And yet we still can't recognize how differently it affects people. A dose of humility would be my order for everyone today. If I could write you a prescription, be grateful for all the people who are trying to help us in the neuroscience field, and have a dose of humility that our consciousness and body and healing works often in mysterious ways that we try to elucidate, but we'll probably have better fortune in trying to heal with by recognizing our individual differences and our commonalities. Most importantly, remembering that we have more power to heal than any pharmaceutical company would ever want you to know. Hey, I appreciate pharmaceutical companies. They give us all these chemicals that I use all day in the operating room. But you have a lot of power as well, and please never forget that. Until next time, oh, please let me know below what you want to talk about on the next live stream. Fill out the polls that I put out there and hit a like if you wouldn't mind, and share with others what you've learned.